No public health. Department of Finance.
Thank you. Carla Castaneda, Department of Finance. We would just add that the proposal includes provisional language given the uncertainty of the waiver, so that this would allow the department to develop the resources as soon as that's approved.
Thank you. LAO.
Our initial review of the proposal is that the workload is likely overstated given DHS's proposed phase-in schedule for waiver implementation. As such, we find that it's likely that fewer positions than requested will be necessary. However, we're continuing to evaluate the proposal, and we will follow up with committee staff as we have more details from our analysis.
Thank you. Public comment? Seeing none, I think we go on to the next item, issue number 4. Thank you all. Health Home Program Resources and Trailer Bill.
Sure. So the actual May revised budget proposal relates to proposed trailer bill that would enable the department to create the fund for the Health Homes program and accept the generous funding from the California Endowment for the non-federal share. Really what this is doing is enabling the department to enact AB 361, which authorized us to develop a Health Homes program to provide enhanced care coordination services for beneficiaries with complex chronic physical and or behavioral health conditions. We have been going through a robust stakeholder process with an initial concept paper released last November and a second version of the paper released last month. We are currently going through the final comments that we've received on that second draft of the concept paper, and we will be releasing another version prior to our submission of a state plan amendment to CMS. We are targeting a January 1st implementation date in counties that are ready. And so that was the need for the language this year in order to be able to accept the funds and begin the program. With respect to the issues raised regarding the CCS program, as I mentioned, the Health Homes program is designed to provide enhanced care coordination services for individuals with complex and chronic physical and behavioral health conditions. Obviously, there is likely overlap with the CCS program. This will be an optional program. It's intended to be additive. It is not intended, and nothing in our proposal would change the CCS services that are currently being received by these children. And we look forward to continuing to work with our CCS colleagues, as well as has been identified, overlap with the CCI program as well, and making sure that we're not duplicating things that are already in place, but really are providing a value added with the Health Homes program.
Thank you. Department of Finance? Nothing from DOF. LAO? Thank you. Public comment?
Good afternoon. Bernadette Ariano from the California Children's Hospital Association. And first of all, thank you for hearing public comment. And I want to thank the department for acknowledging that there may be overlap with the CCS department. CCHA is very supportive of the Health Homes program. We are very concerned about the potential for overlap and how that might be solved. We're aware that it is an optional program, but we are concerned what would happen if a family did choose to enter a health home, how that might be resolved. So we thank you for consideration of our concerns. We did submit potentially some amendment to the trailer bill that the department has proposed, and we are looking forward to working with the committee and with the department to try and resolve some of our concerns in the next couple of days. Thank you very much.
Mr. Chair and members, Tim Shannon representing the Children's Specialty Coalition. We are the pediatric subspecialists who work in the children's hospitals. We share the same concerns and issues raised by the Children's Hospital Association. There is an overlap between the population that will be served by the Health Homes program and the CCS program. As you are aware, there is a undertaking from the Department of Healthcare Services about redesigning the CCS program. We've been involved in that for the last year. We look forward to discussions with the department to clarify and make it clear that our pediatric subspecialists and hospitals that currently serve this population will be able to continue to do so in a seamless fashion. Thank you.
Thank you, Mr. Chair and members. Terry Calgar-Hill on behalf of Children's Hospital Oakland, as well as the California WIC Association. I would like to support the comments made by my previous colleagues. We too have concerns with the CCS population. These are very vulnerable children with heart conditions, cancer, and we want to make sure that this new health home proposal doesn't have any adverse impact on them or the CCS providers who provide their care. And again, we're not opposed to health homes. We think that model is a good one, but we just want to make sure that these very vulnerable children, as part of the CCS program, are taken care of properly. Thank you very much.
Laurel Mildred, California Association for Adult Day Services. We have had for 2 years a pilot project throughout the state running a grant-funded health home that's designed to national standards. We have submitted comments on the Concept 2.0 paper. I won't take your time. We have feedback on 10 different items. I will submit it to the committee in writing. But prominently, I just want to notice that reducing healthcare costs is seen as involving two discrete things. One is coordination and one is provision of social services. But the health home design does not provide for any social services. It assumes that they are available in communities. And we think if there isn't enough attention given to social services, the health home will not get the outcomes that it's designed to get. Thank you.
Linda Way with Western Center on Law and Poverty. As one of the co-sponsors of AB 361, we support the proposal and look forward to continue working with the department on this.
Tam Ma with Health Access California. We were also one of the organizational supporters of AB 361 and look forward to continued work on this issue. Thank you.
Okay, that concludes public comment on this issue. Why don't we now go to issue number 5 around the ground emergency medical transportation trailer bill, and let's first hear from the department.
Sure. So we currently have an existing supplemental payment program for public GEMT providers in fee-for-service. Last year, those providers sponsored a bill, AB 2577, that was attempting to replicate that same supplemental payment structure in managed care. The bill was vetoed by the governor, who directed the department to continue to work on options for exploring additional increases to the supplemental payments. There is no general fund impact, as the non-federal share is provided by the public GEMT providers. As we worked on options, we determined we would be unable to replicate that exact structure in managed care and looked for alternatives. One alternative we developed was to explore whether there are ways to increase the fee-for-service supplemental payments by moving from a CPE cost-based structure to an IGT-based commercial supplemental structure. The proposed trailer bill would allow the department to continue to work with stakeholders and implement a revised version of the fee-for-service program only if it resulted in increased funding, and the existing program would not stop until and unless a new program was put into place.
Okay, Department of Finance, LAO. Okay, let's hear any public comment on this item.
Mr. Chair and members, Tim Cremoni on behalf of the League of California Cities. Thank you for an opportunity to comment. We have no position on this trailer bill, but we do have some concerns about it based on the fact that the current language may be potentially harmful to local agencies by deleting ground emergency medical transport in some jurisdictions potentially. We would therefore encourage the department to continue to work with the local agency stakeholders to resolve that difficulty.
Great, thank you. Seeing no other public comment, let's go on to issue number 6 around the application assistance payments trailer bill. Let's hear first from the department.
Yes, Renee Mulla, Department of Healthcare Services, and we've been asked to respond to 3 questions regarding the application assistance program. And so given the changes that are going to be underway through Cover California, because today they currently hold the contracts with the certified enrollment entities and the certified insurance agents, and they make the payments on behalf of the Department of Healthcare Services for the application assistance that is provided to individuals who ultimately become eligible for the Medi-Cal program. And so given that they're going to be moving to a new Navigator program, the Department of Healthcare Services does not have the infrastructure in order to support maintaining this program in its current form. So what is being proposed by the trailer bill language is that for applications that are received up through and including June 30th, that the entities that supported those applications would be reimbursed, and then for any monies that may then be remaining, that those monies would then be reallocated to counties that are participating in outreach and enrollment grants. That in both of these projects, both the application assistance project as well as the outreach and enrollment grants, are funded in part by grant funds that were provided to us through the California Endowment, and then we match those monies with federal funds. And so in looking at options available to us, we believe that what we have provided through May Revise is the most appropriate course of action for us to take, given the limitations that we would have in terms of continuing the funding for this program. Through the outreach and enrollment grants, in terms of the monies that are allocated to them, I do want to point out that we do have requirements in the contracts with those counties. The allocations are made to counties, but through those allocations are also required to work with and engage with community-based organizations in terms of doing the outreach and enrollment activities. And in terms of the success of the two programs, we have seen the success in terms of the applications that have been assisted. And we have also learned that in terms of the work that the counties are doing for the outreach and enrollment, while we don't have data right now, we have learned, again, that those populations that were targeted for those funds are the most difficult to reach in terms of identifying those populations and getting them into coverage. And we have learned that there's lots of touches that are needed. We do work on receiving progress reports. The counties did have some delays in terms of getting their programs up and running because they did have to seek Board of Supervisor approval as well as go out and do contracting with community-based organizations. And at this point in time, those contracts have been approved with community-based organizations. Boards of supervisors have given their approvals for the acceptance of these grant funds, and we believe on a go-forward basis we're going to be seeing more output in terms of the work that they're doing, and they'll also be providing us with periodic progress reports on their efforts and their successes in terms of the outreach and enrollment.
Thank you very much. Any other comments, Department of Finance? LAO? Okay. Let's go to public comment.
Good afternoon, Tam Ma from Health Access California. We very much appreciate the department's administration of this grant money, which has helped many low-income individuals and families to apply for and stay on Medi-Cal. With regards to the proposed trailer bill language, we are concerned that the in-person enrollment application assistance is not being continued for Medi-Cal. We think that the $58 payments per application that have been made to certified enrollment counselors and insurance agents have been a very critical part of this assistance program. If the remaining funds are transferred to the county outreach and enrollment grants, as this trailer bill proposes to do, we hope that the community-based organizations will be able to continue accessing these funds and continue doing the good work that they're doing with these enrollment activities. Thank you.
Linda Way with Western Center on Law and Poverty would like to align our comments with Health Access. We too are concerned with the proposal as we believe the remaining funds should be used as was the legislative intent and be based per application.
Kathy Dressler on behalf of the Children's Health Coverage Coalition, which includes the Children's Defense Fund, the Children's Partnership, the United Way, PICO California, and Children Now. Wanted to urge continued funding so that we can get at least the last 160,000 children in California who are eligible for Medi-Cal but not enrolled by 2019. This population is, for multiple reasons, much harder to reach than the group who enrolled in the first 2 years of coverage expansion. Additionally, we know that children of color and those living in mixed immigration status households are less likely to have coverage and will require time-intensive and targeted outreach. So we hope that we can continue to invest this money for that population. Thanks so much.
Thank you very much. Thank you to the panel. Why don't we now go to the Department of Public Health's issues and to the first issue of licensing and certification with regard to the May revised adjustment for the Los Angeles County contract.
Good afternoon, Mr. Chair. Jean Icino, California Department of Public Health.
Whoever's presenting.
Okay, thank you. So our May revised proposal for our LNC estimate, the major change is an increase of a request for $5.3 million to augment the proposed funding for our Los Angeles County contract. This increase takes into account some fixed costs that we were unaware of or have changed since November for Los Angeles County, including 2 salary increases that the county has contracted for since the fall, accounting for the employee benefit rate for the county, for a difference in their full-time equivalent hours compared with the state, and for the indirect cost, the county's indirect cost rate.
Okay, thank you very much. Any other comments from the Department of Finance? LAO?
Sean Martin with the Legislative Analyst Office. We note that a report is overdue that would help us to evaluate whether the approach the Department is taking towards staffing is the most cost-effective approach. So until we receive that report, we're not able to tell you if this is actually the best way to go about ensuring licensing and certification activities take place.
Okay, thank you very much. Let's go to public comment. 1 minute per speaker.
Good afternoon. My name is Cynthia Harding, and I am the interim director for the Los Angeles County Department of Public Health. And I want to thank both the administration and the CDPH staff for working with us to secure a new 3-year contract. Our current contract ends on June 30th, and so we are hopeful that we can continue this contract. The LA County Board of Supervisors supports the governor's proposal for the $9.5 million in the January proposal and the additional $5.3 in the May revise for a total contract amount of $41.7 million. And our board's first and foremost priority, I want to stress, is to ensure the health and safety of the vulnerable populations in these health facilities. And this additional funding is absolutely crucial for our county to fulfill the licensing and certification requirements and responsibilities that we perform on behalf of the state. I've stated before that we've had this program since the 1960s, and if this new contract and additional funding are approved, we are going to fast-track the hiring of new staff to get them on as quickly as possible, because I want to remind you that it takes 12 to 14 months before these staff can be productive in the field and work independently. And so we'll begin to experience notable staff productivity in fiscal year 16-17 with a full phase-in of new staff and productivity in fiscal year 17-18. And again, I hope we can get your support on this. Thank you.
Good afternoon. Michelle Cabrera with SEIU California. On behalf of our state and LA County health facilities evaluator nurses who perform this work on behalf of licensing and certification, we urge the committee to support the May revision proposal with the adjustment for LA County. In terms of cost effectiveness, I just want to note that after our SEIU local in LA County was able to bargain for better wages for our health facilities evaluation nurses, our turnover rate was cut in half and was down to 5.8% in 14-15 compared to the state's turnover rate of 21%. This is huge in terms of what we're facing in trying to turn this program around, as it takes over a year to train someone and bring them on board in this program. This is a very specialized field working with a lot of details and really important public safety matters. So we urge the committee to consider the investments that are required up front, the risk of losing staff as they're recruited away by the regulated industry, and the need to really stabilize this program ongoing. And we thank the department for their acknowledgement of the needs of this program and urge your support. Thank you.
Thank you. Next speaker.
Thank you. My name is Sheree Rostami, and I'm with LA County Department of Public Health. I'm a health facility evaluator nurse. And I started with the county in 99, left in 2005, came back 2011. And this is a very much needed proposal, and I'm very happy that we're making some progress here. We were way behind in doing the workload, and we do need a lot of other nurses. And it is a highly trained field. It's very diligent, very detailed work, and so we're just very happy, and we appreciate your assistance. Thanks.
Next speaker.
Good afternoon. My name is Selena Pryor-Dansby from SCIU Local 1000. We're supportive of the increase for LA County. However, we represent the state workers, and we have not been able to negotiate any raises in our contract. And so what we're doing now is we're helping with the workload in LA County, and the pay parity continues to impact the state's ability to retain staff. So the state's losing out on its investment, and we believe that the state must act to increase the state's LNC staff pay. Otherwise, we'll continue to have retention issues that lead to quality of care issues. So with that, thank you.
Thank you for that public comment. Why don't we now go to the second issue under the Department of Public Health around genetic disease screening programs, prenatal screening trailer bill. And let us first hear from the department.
My name is Connie Mitchell. I am the Deputy Director of the Center for Family Health. Genetic disease screening is one of the divisions in my center. This trailer bill involves funding. Health plans and insurers are required to provide coverage for prenatal testing, which we do through the genetic disease program, and it mandates that the Department of Public Health is the sole statewide provider of prenatal screening. And so what we found happening is that insurance companies are routinely negotiate, and their groups negotiate for different rates of reimbursement. And it has been determined by multiple companies that the genetic disease screening program is considered an out-of-network provider. So subsequently, our reimbursements are lower, and we cannot balance bill for these. And so what we're requesting is that the private health plans and the insurers no longer consider the department as an out-of-network provider, and that they be required to pay the full fee. The fee is $207. It's set by regulations. It covers all services of the genetic disease screening program.
Okay, thank you very much. Department of Finance. Elio, any public comment on this issue? Seeing none, thank you for your presentation. And why don't we continue to the issues under the Department of State Hospitals. The first issue will be the restoration of competency program expansion. From the department.
Good afternoon, Chair and Chair. My name is Pam Allen, Department State Hospitals Director, and this is Stephanie Clendenin, who will present our items.
Good afternoon. We were requesting $10,102,000 in general fund support to expand our jail-based restoration of competency treatment programs by up to 108 beds. Expanding our capacity to provide restoration of competency services in the jail will help to reduce the ongoing wait list for our incompetent to stand trial, or IST, patients. This proposal also includes trailer bill language to eliminate the sunset date for the ROC programs and will allow for the continued operation and expansion of the ROC programs beyond the current sunset date, which was January 1, 2016. Of the $10.1 million that's requested, $6.1 million is to expand the existing 20-bed San Bernardino County ROC program by an additional 76 beds to serve both San Bernardino County and Los Angeles County IST patients. This contract has been finalized, and these beds will be activated beginning next month. For the remaining $4 million, discussions with counties continue, and therefore we're requesting to add funding for up to an additional 32 beds and requesting provisional language be added to allow the Department of Finance to authorize expenditure authority for this portion once county approval of contracts is obtained and with a 10-day notification to the legislature. We continue to have a wait list for our IST patients. As of May 11, 2015, there were 270 patients on the wait list, and patients continue to wait over 30 days for placement in a state hospital. It is important to note that the expansion of the jail-based competency treatment program is a critical factor in reducing the IST waitlist, but will not alone solve the IST waitlist problem. The jail-based competency treatment program serves a subset of our IST population, primarily IST patients who do not require involuntary medications, who are willing to participate in treatment, and whose mental health condition will provide for competency restoration on a relatively short-term basis. This proposal, along with the governor's budget proposal to activate the 105 state hospital beds at our Atascadero and Coalinga State Hospital that was presented to the committee at a prior hearing, are both needed to reduce the IST waitlist in the current year.
Any other comments, Department of Finance? Elio?
Drew Soderborg, Legislative Analyst's Office. We don't have any concerns with the proposal to expand ROC capacity. In fact, we're actually recommending an additional $6.2 million for 50 additional ROC beds. However, we are recommending that these beds be approved in lieu of the $17 million that was proposed in January for 105 IST beds, which would be activated in DSH facilities. We find that a further ROC expansion would be the most cost-effective way to address the IST wait list. And while it is true that ROC beds can't serve all IST patients, by activating more ROC beds in the community, we'll be able to serve more patients in the community, which would free up beds in IST in the hospitals, which could serve any IST patient.
Okay, thank you. At this time, the staff is recommending holding open this proposal to allow for more time to review. Let's go to public comment.
Mr. Chair and members, Kobe Posada with California Association of Psychiatric Technicians. Regretfully, we must oppose this increase in funding, as we do not believe the ROC program is the least restrictive environment in which to treat an individual with mental health issues. Somebody with mental health issues should be treated in an open hospital type setting rather than being locked up in a jail. Furthermore, the ROC program it sort of cherry picks those individuals that are the easiest to treat. When you have individuals in a state hospital currently that are incredibly volatile and very dangerous, and they're in an open campus setting. So it would stand to reason that the individuals that are the most dangerous would be needing higher security rather than the ones that have the least amount. So with that, we must oppose this. Thank you.
Okay, seeing no public comment, let's go to the next issue regarding the Coleman bed expansion in Vacaville. To the department.
Yes, good afternoon. My name is George Maynard, Deputy Director for the Hospital Strategic Planning Division for DSH. And we're proposing the opening of a 30-bed unit at the CMF facility at CDCR to accommodate additional growth in our Coleman class patient. We worked with the Department of Corrections to identify the 30-bed unit and off-unit treatment space to activate DSH Vacaville. We're requesting and may revise 38.2 positions and $4.6 million in general fund budget year and 38.2 positions and $5 million ongoing. This will complete the capacity increase at Vacaville to meet the demand of the increased utilization of CDCR in the mental health program.
Okay, no Department of Finance. Elio?
We don't have any concerns with the proposal.
Public comment. Back again.
I have a little something to say on everything. As Kobe Posada with California Association of Psychiatric Technicians, we support this proposal. Thank you.
Next speaker.
Selena Pryor Dansby, SEIU Local 1000. We also support.
Mark Victoria, AFSCME Local 2620. We also support this proposal.
Seeing no public comment again on this item, the staff has recommended holding this open to allow additional time to review. Let's go to issue 3, civil commitment bed expansion.
We are requesting $26,000 in general fund reimbursements and 67.1 positions to activate a 40-bed unit at our Metropolitan State Hospital to serve the Landrum and Petrus short patients, or LPS patients. These are the civilly committed or conserved patients, and the counties pay a daily bed rate for placement of their patients. The activation will begin at the end of this month and will address a growing wait list of county commitments. In activating this new 40-bed unit, we plan to transfer from other units LPS patients who are suffering from chronic medical conditions that do not require care in a skilled nursing facility placement. This will place the more medically fragile patients together on a single unit and allow the clinicians to provide more efficient care and treatment. Additionally, it will separate these patients from other LPS patients with higher levels of mobility and aggression. Once the unit is active, Metropolitan will fill the newly available beds in the other units with patients from the LPS waitlist and or new incoming LPS referrals. You asked for us to describe the increase in the wait list and what has occurred over the past year and what might be contributing to the factors, what are the contributing factors to this increase. So the wait list has grown from 10 in July of 2014 to currently is 43. We think a factor that may be contributing to the growth is our change in billing rates and billing processes for LPS beds. Prior to this fiscal year, a county had to essentially contract for a specific number of beds at an ICF or acute level at the beginning of the year, and then we had to reserve the beds for that county. Throughout the year, if a county's beds were full, if they needed to place someone, then they basically had to exchange a patient for a patient, or if a county had not reserved beds, then they had to negotiate with other counties to try to obtain placement for a bed from that other county in order to place their patient. Each month they paid 1/12 of the cost of the reserved beds, and if they weren't full, they still paid for the full contracted number of beds. Now there is no longer any requirement to reserve the beds. They are billed for the actual bed use, so we think that may be what's contributing to this increased growth.
Okay. Again, no Department of Finance. Elio, any public comment?
Mark Victoria, ASME Local 2620. We stand in support of this.
Changed up the order a little bit. Kobe Poseida with California Association of Psychiatric Technicians. We're also in support.
Selena Pryor Dansby, SEIU Local 1000 is support.
Again, staff has recommended holding this proposal open for additional review time. Why don't we go to the final issue under the Department of State Hospitals around earthquake repairs and seismic upgrades.
$5,725,000 in general fund support and $17,175,000 in general fund reimbursements to repair damage caused at the Napa State Hospital by the magnitude 6.0 South Napa earthquake that occurred last August. We are also requesting provisional language to authorize a general fund loan to provide cash flow to pay for these repairs and will be repaid upon receipt of the federal reimbursements. The second project we are requesting is we're requesting $4,042,000 in capital outlay funding in the budget year for preliminary plans, working drawings, and construction funding to seismically retrofit the plant operations building at Napa State Hospital. Because this earthquake was a presidentially declared federal disaster, federal funding is available for both of these projects. FEMA will provide reimbursement of up to 75% of the cost of the project, and the state share being 25%. The Earthquake Damage Repairs Project will provide repairs for 39 buildings at the Napa State Hospital that were heavily impacted by the earthquake. This funding will repair collapsed chimneys, cracked interior and exterior walls, cracked roofs, and foundation damage, which, if left unrepaired, may result in mold, water, and insect intrusion and dry rot. The seismic retrofit project is for the plant operations building at Napa State Hospital that houses the hospital's glasswork, plumbing, and carpentry workshops, as well as various plant operations staff offices. The building is made from brick, or considered unreinforced masonry, and was built in 1916. These types of buildings, especially with considerable age, are especially prone to a collapse in an earthquake. Due to the risk of collapse, we're proposing to seismically retrofit the building. This project is being funded via the FEMA Hazard Mitigation Grant Program, which is intended to be used by applicants to reinforce structures to make them more likely to be able to survive a future disaster. There were three questions that you asked that we addressed. First of all was what we know about the level of seismic safety of all of our state hospital structures. We operate 5 hospitals that were built over a span of 130 years. 3 were built in the late 1800s and early 1900s. During that span, obviously, earthquake science and building materials and codes have changed greatly. Our structures were built according to code at the time of construction, but as earthquake science has evolved, those standards have become outdated, and some of DSH buildings, particularly those that are older and have not been renovated, may have seismic deficiencies. At various times, DSH buildings have been evaluated for seismic stability. These evaluations happen for various reasons, including studies for proposed capital outlay projects or master planning efforts. However, the department does not have a comprehensive seismic evaluation data for all of its buildings. Do we have a seismic safety upgrade plan for the state hospitals? After the South Napa earthquake, we began working to compile seismic evaluation data on our facilities into a single record. However, some of the records are old, and not all buildings have had evaluations. However, the department has historically attempted to ensure that buildings evaluated and identified as being seismically deficient were retrofitted to address those deficiencies. When a building is evaluated for seismic stability and identified as having a risk level of 5 or higher on the Department of State Architects 7-point scale, these buildings are typically slated for retrofit to a level of 3. And we do actually have a proposal, which was already heard before this committee this fiscal year, proposed for the next fiscal year to upgrade our seismic corridor. The east-west corridor at our Atascadero facility. So we are continuing to work on seismic upgrades at our hospitals. And do we believe that the hospital structures are sufficiently and appropriately seismically safe for both patients and staff? We are aware that facilities may have potential seismic deficiencies, and in light of the South Napa earthquake, we are actively working to identify the best way to secure funding and approach evaluating and mitigating any seismic deficiencies.
So, listening to your answers to the questions that were proposed, it doesn't seem as if we really do have a handle on seismic safety for our state hospital structure. We have some anecdotal information, but we really don't know what the picture is.
That's correct. We do not have a full comprehensive evaluation of all of our hospitals.
And there's no immediate plan to do that evaluation.
We are working to identify and look at opportunities for funding to do an evaluation.
Okay, but nothing on the immediate horizon?
Nothing currently.
Are you concerned about that?
Well, I mean, yes. There's always an opportunity every day within California for there to be an earthquake, and so we are looking at ways for us to fund an evaluation project.
I know we require most other hospitals in the state to come into compliance by this year, but obviously these hospitals were not required to come into that compliance.
That's correct. The state hospitals were exempt from SB 1953.
Okay, can you remind me of why that was the case?
I don't know.
Okay.
Yeah.
Okay. Department of Finance? Nothing? LAO? Public comment? Okay, seeing none. Let's go to the Health Benefits Exchange. We still have to do that. We're still. This last time. Happy for you to take it back. No. We have one issue under this item, which is the Emergency Regulations Authority.
Thank you, Mr. Chairman. David Panish with Covered California. I also have Brandon Ross, our Deputy General Counsel. Last year, Covered California requested a 2-year extension for its Emergency Regulation Authority. We needed the flexibility to accommodate changes in federal regulations and other changes related to Affordable Care Act implementation. We were allowed a 1-year extension, and since then, we have been moving to make permanent as many regulations as we can in a number of areas, including fingerprinting, background checks, small business appeals, and enrollment assister navigator program. But federal regulations continue to change and necessitating changes in our regulations, particularly in the critical area of eligibility and enrollment. Our current emergency regulations will expire this summer, which will leave us without legal authority in a number of key areas, which is why we are requesting an additional 1-year extension. Second, the proposed trailer bill language exempts our standard plan designs from the formal rulemaking process. Without this exemption, we would be required to do new permanent regulations every year to reflect changing federal rules such as the actuarial value calculator, which changes every year. To ensure transparency, the standard benefit design would be subject to approval by our board after at least 2 publicly noticed board meetings. Finally, for procurements, the language required the board to adopt a contracting manual containing the same processes and requirements as the state contracting manual, so that a formal rulemaking process won't be required every time we issue a procurement, as we do in the case of our qualified health plans, for example. So with that, we appreciate your consideration and would be happy to answer any questions.
Okay. Any comments from the committee? Department of Finance?
Thank you, Assemblymember Chu. Mr. Chair, Guadalupe Manriquez with the Department of Finance. The administration would like to note that some emergency regulations promulgated by Covered California impact the Medi-Cal program, given that eligibility determination and enrollment for insurance affordability programs such as Medi-Cal are processed via a single streamlined application. For example, the regulations related to enrollment assistance applies to entities and individuals that assist Californians to apply for coverage through Covered California or Medi-Cal. Not extending Covered California's rulemaking authority and allowing its emergency regulations to be amended and readopted for the additional time period to be able to promptly address changes in federal guidelines could lead to inconsistencies between federal law and state regulations. This could create uncertainties that could affect how individuals are enrolled in the Medi-Cal program and the health insurance exchange. Thank you.
Leo. Okay, let's go to public comment.
Linda Way with Western Center on Law and Poverty. We talked with Covered California earlier today and understand these are technical and conforming changes, so have no issues.
Tam Ma with Health Access California. We also have no concerns about this proposed tailable language.
Okay. The staff has recommended that we hold this item open. Let me ask any other questions from the committee, Mr. Chair? Okay, with that, I think we are at the end of today's agenda. Appreciate everyone coming out, and at this time, this meeting is adjourned.